We'd like to welcome you to the webinar, LALD, a rare disorder that mimics fatty liver disease. This is Deborah Enton of the American Liver Foundation, and I will serve as moderator of today's program. The American Liver Foundation serves as the national voice of all people with liver disease, and our webinar programs are just one of the ways we fulfill our commitment to help people become knowledgeable about their condition and be their own best advocate. Today we'll be discussing a rare genetic disorder called Lysosomal acid lipase deficiency, or LALD for short. LALD can affect people of all ages, from infancy through adulthood. However, the disease presents very differently across the lifespan. Further complicating the diagnosis of LALD is that there can be considerable overlap in terms of clinical and laboratory findings between LALD and the more common disorder of fatty liver disease. To shed some light on this, we're lucky to have Dr. Barbara Burton, one of the nation's foremost experts in LALD, as our speaker today. Dr. Burton is professor of pediatrics at Northwestern University School of Medicine and clinical practice director in the Division of Genetics, Birth Defects, and Metabolism at the Children's Hospital of Chicago. Her major clinical and research interests are in the area of inborn errors of metabolism. She was the lead investigator in the phase 3 trial of Kanuma, or sebelipase alpha, a new treatment recently approved for LALD. Dr. Burton is the past president of the Society for Inherited Metabolic Disorders and a member of the Genetic and Metabolic Advisory Committee of the Illinois Department of Public Health. She has contributed over 200 articles and chapters to the medical literature, many of them focusing on the diagnosis and treatment of inborn errors of metabolism. We are pleased to have her join us today. In a moment, I'll review the objectives of the program. This will be followed by 2 survey questions where we'd like your participation. We'll then hear Dr. Burton's presentation, followed by a live question and answer session. The objectives of today's program are for you to be able to describe what LALD is, identify how it's diagnosed, list 3 potential complications of the disorder, give 2 examples of how LALD and fatty liver disease overlap, and list 1 management option for the disease. Now, I want to make sure that you're ready to participate. On the right-hand side of your screen, you should see a box where you can type in questions. If you don't see it, click on the orange button, which will make it appear. Simply type your question in the box and click Send when you're ready. Please feel free to send us questions both during and after our speaker's presentation. When you submit a question, tell us your first name and city if you'd like. We'll try to get to as many questions as possible, but if you still have questions after the program, you can contact our help desk by calling 1-800-GO-LIVER or open the chat window that appears in the lower right-hand corner of the American Liver Foundation's homepage on their website. If you are a patient with liver disease, please select the category that best describes your diagnosis. Okay, we're getting answers coming in. We have about 6% of the people have a diagnosis of LALD. And then there's a large percent, 34%, of other that we don't have something to describe that. So I think what we're seeing is that people with fatty liver disease, a good percent of the audience, they're quite interested in hearing about the overlap and learn a little bit more about these 2 diseases. Okay, we appreciate your participation in the poll. Your answers help guide us in tailoring the program to meet your needs. Now that we've heard from you, we're going to switch over to Chicago, Illinois, and hear from our guest speaker, Dr. Burton. Dr. Burton, you should now have control of the mouse. Please begin.
Very good. Thank you so much, Deborah. It's really my pleasure to be with you all today to talk about LALD, which really is an unrecognized disorder, oftentimes under-recognized, but certainly a very treatable one. So increased awareness is so important. Let's start by talking about really what is LALD. This is a disorder with a very complicated name, lysosomal acid lipase deficiency, which is why we use LALD for short. It is an inherited, a genetic disorder, and it is the result of a deficiency of an enzyme, the LAL, lysosomal acid lipase, that breaks down fats and cholesterol in your cells. You know that all the organs of the body are composed of little subunits called cells, and within the cells, the fats are broken down by this enzyme. In people with LALD, the enzyme either does not work well or at all, and their cells can't break down these fatty materials, so they build up in the liver, the spleen, and other organs, causing problems throughout the body. This next slide shows you graphically a little bit about how this works. Now, we talked about cells being the little subunits inside all of our organs, but within the cell, we have even smaller subunits that have specific functions. And the LAL breaks down cholesterol in the part of the cell that's called the lysosome. So inside each cell, we have a number of different lysosomes that have different functions in breaking down various materials. So you're seeing a graph of a cholesterol particle that contains both cholesterol esters and triglycerides going into the lysosome of the cell, where these little purple dots, which really are representing the LAL, the enzyme, go to work and break them down and then release the smaller particles that have been broken down out into the cell. Now, in the next slide, we'll see what happens when we don't have enough LAL activity, either too few purple dots or they just don't work well. These same cholesterol and triglyceride particles get into the lysosome, but there's not enough LAL to really break them down properly, so progressively they accumulate inside the lysosome of the cells, and over time this leads to damage to the cells and to the organs. So we'll look at this next slide at some of the possible complications that we see as a result of this fat accumulation. In the liver, we see liver damage, which can be observed in the form of an enlarged liver, and as the fat continues to accumulate in this enlarged liver, it does damage to the liver, causing liver scarring with fibrosis, that scar tissue, and then ultimately cirrhosis, and this leads to liver failure. In the cardiovascular system, we see problems because of the high levels of the LDL, which is the bad cholesterol in the blood, that go along with this disorder. So not only do we have the fats accumulating in the cells, but we have high levels of this bad cholesterol in the blood. And this leads to atherosclerosis and an increased risk of heart attack and stroke. We also can see problems in other organ systems, like the spleen, where we see enlargement of the spleen, which causes it to become overly active, chewing up blood cells. So you can get low platelets in the blood, or anemia, not enough red blood cells. We also see problems in the gastrointestinal or the digestive tract. We can see abdominal pain, poor absorption of food, gallbladder problems, sometimes bleeding in the GI tract, or diarrhea. So problems in many different parts of the body. And other complications that can be observed include poor growth. If you have malnutrition, can't absorb your nutrients. You'll see poor growth. If you have early cirrhosis, you'll see poor growth. And we can sometimes see calcium deposits in the adrenal glands, which are little glands that sit on top of the kidney. Now, we mentioned that LAL-D is a genetic disorder. On this slide, you're seeing a diagram of how the genetics of this disorder work. This is what we call an autosomal recessive disorder. Genes in the body typically occur in pairs, with one member of each gene pair coming from the mother and one coming from the father in the egg and the sperm cell. A recessive disorder is one that causes problems or disease only when an individual has two copies of that recessive gene and no normal gene in that gene pair. And that usually occurs when both parents are what we call carriers of the gene. As you see here, they are perfectly normal because they have one normal gene, that's the gene in yellow or light green on in their gene pair, but they also carry one of the dark blue copies, which is the gene for LAL deficiency. Because they have one normal gene, they have no symptoms whatsoever and normally wouldn't know that they are both carriers of the same recessive gene until they have a child who's affected with the disorder. Now, each time a couple who are both carriers of a recessive gene have a child, there's a risk of 1 in 4 or 25% that the child will inherit two copies of the recessive gene, like this boy here, and therefore have the disease. Whereas there are 3 chances out of 4 that the child would either inherit only normal copies of the gene or just one copy of the recessive gene and would be perfectly normal. Now, the gene that is affected in LAL-D is referred to as the LIPA gene, L-I-P-A, and this is the gene that is responsible for the production of the enzyme, the lysosomal acid lipase. So if you have a mutation or a change in that gene, it leads to little or no LAL enzyme activity. And obviously, if you have 2 copies, then you're going to have little or no activity in your body, and that's when you have the condition that we call LAL-D. So who among us has LAL-D? Well, we know that LAL-D can affect people of all ages, even though the genetic information that says you're going to have LAL-D is there from the moment of conception and certainly from birth. You may not be diagnosed or have obvious clinical symptoms until somewhat later, and that can be in infancy or it may not be until adult life. We know that the disorder affects both males and females with equal frequency, and individuals of any ethnic background can have LAL-D. Now, infants who have the most severe form of the disorder typically begin to show severe symptoms at about 1 month of age. So they're very obvious. We see that these are sick babies very early on. But in children and adults, and it's more common in children and adults, symptoms can either appear early as 2-3 years of age, or not until adult life. And actually, patients may have no symptoms or complaints whatsoever and may have this disorder. And we'll talk a little bit about how it can be recognized in individuals who actually feel fine, look fine, don't have symptoms, because the disorder can progress without obvious signs and symptoms until very late in the course of the disease. For example, individuals who have liver disease from LAL-D, they often look and feel perfectly fine until their liver disease, cirrhosis, is very severe and they're headed toward liver failure. Fortunately, the disease may be picked up earlier because doctors may do blood tests that show that something's going on in the liver, or they may notice the liver's enlarged. But often the patient feels just fine, which makes this a somewhat difficult disorder to diagnose, and why it's so important for us to be talking about it and really getting increased awareness of the disorder. On this next slide, we're showing you that this is one disease that can present really throughout infancy on into adult life in patients of any age, all related to changes in this same one gene, leading to a deficiency of this same enzyme, but with different degrees of severity. So in infants, babies, I mentioned, they are very sick when they present with this disorder. We see persistent vomiting and diarrhea, liver fibrosis and liver failure very early, very serious problems with weight gain and growth, and the actual median age of death in infants with this very severe form is 3.7 months if the disorder is not diagnosed and treated. This very severe form of the disorder has previously been referred to as Wolman disease, but we now know that it's really the same disorder that we see in children and adults, but just in a more severe form, which is why we tend to use the term LAL-D for all patients now. In children and adults, the disorder may be diagnosed because the patient has evidence of liver disease or a big liver with fibrosis and or cirrhosis. We see premature cardiovascular events, heart attack and stroke, high cholesterol in the blood, and this form of the disorder has in the past been referred to as cholesterol ester storage disease. But again, it's the same as Wolman disease, just a different degree of severity. In this next slide, we talk again about some of the most important signs and symptoms of LAL-D that may bring this to a physician's attention. In infants who are very sick, we typically see the poor growth and the enlarged abdomen. These things are obvious. So the babies obviously are sick, and if the physician can establish the correct diagnosis, then there is therapy, but otherwise this is typically a fatal disorder in early infancy. In toddlers or children with LAL-D, often the disorder is first recognized because the abdomen appears kind of big, there's a pot belly, or an enlarged liver is felt on a routine physical exam, maybe just when the child goes to the pediatrician. If it's not recognized until adolescence, or it's a little less severe than that, it may be picked up because there's an abnormal, what we call lipid profile, cholesterol level picked up on routine screening. Pediatricians are now doing routine testing for cholesterol in the blood on teenagers to help prevent atherosclerosis, and patients may be picked up because they have a high cholesterol level. In adults, sometimes the first sign may be elevated liver enzymes detected on routine testing. If an adult patient goes to an internist for a checkup, very often they will get some routine chemistries done on an annual basis, and this includes a measurement of liver enzymes like ALT and AST, and this may be how it's first recognized that this is a patient who has something going on in the liver, and then further testing and evaluation can confirm the diagnosis of LAL-D. Now, if a patient like that also has an abnormal lipid profile, high cholesterol in the blood, this should very much strengthen the doctor's suspicion that we're dealing with LAL-D. So if you have high liver enzymes and abnormal cholesterol, this is a situation where we absolutely have to think about LAL-D and evaluate for this possibility. As I mentioned previously, LAL-D can go unrecognized for a long time and sometimes probably is never recognized in a patient who may just felt to be having some unknown cause for their liver disease. It's relatively rare, so many physicians may be unfamiliar with the disease and with the diagnostic tests that can be performed to either confirm it or to rule it out. There is overlap with a lot of more common conditions, such as fatty liver disease, which we're going to discuss a little bit more, but also it may overlap with the common form of high cholesterol in the blood, familial hypercholesterolemia, and a number of other common causes of liver disease or high cholesterol. And as I mentioned, patients can outwardly look and feel healthy until the condition is very advanced. So it's very important that we pay attention to these early signs and symptoms to try to prevent it from progressing to that stage. Now, the focus of our discussion today is really the overlap with fatty liver disease, and there is significant overlap in both LAL-D and fatty liver disease, also referred to as NAFLD and NASH. That stands for non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Together, those are forms of fatty liver disease. And in both LAL-D and these conditions, we see excess fat in the liver. We also see elevation of those liver enzymes that I mentioned, the ALT and AST, telling us that there is irritation going on in the liver. Liver biopsy, if it's performed, is associated with excess fat. You see the excess fat in the liver, and sometimes in both of these conditions, you may see fibrosis or cirrhosis. And these similarities can lead a physician to make a presumptive diagnosis of NAFLD, fatty liver disease, in a patient who has these findings. Now, there are some differences between LAL-D and fatty liver disease, and one of these is that obesity is strongly correlated with fatty liver disease. Most patients who have non-alcoholic fatty liver disease are obese because they have excess body weight, they have fat in their adipose tissue, fat throughout the body. They also have more fat accumulated in the liver. Patients with LAL-D have a normal body weight, although of course anyone in the population can have a problem with obesity. It's pretty common, so there's nothing to keep a patient with LAL-D from being obese, but they're not obese any more commonly than we would expect in the general population. So many of them have a normal body weight. So if you have a normal body weight but excess fat in the liver, definitely you need to think about the possibility of LAL-D. This slide shows you some of the things we just discussed, graphically. In the green circle, we're looking at some of the findings that we see in fatty liver disease, NAFLD and NASH, whereas in the pink, we're seeing the findings in LAL-D. And where they overlap, these are things that we see in both conditions, the elevated liver enzymes and the fat in the liver, fatty liver. But as I mentioned, with fatty liver disease, NAFLD, NASH, typically we have obesity, whereas not necessarily so in patients without LAL-D, and patients with LAL-D typically have a very elevated bad cholesterol level, that's your LDL cholesterol, and they also have a reduced good cholesterol. So there's sort of a double whammy for risk of heart disease, because you'd like to have a normal good cholesterol that protects against heart disease, whereas this high LDL cholesterol very much increases your risk of atherosclerosis, heart disease, and stroke. Now, there are also some differences between LAL-D and fatty liver disease. with regard to the rate at which the liver damage progresses and the likelihood that a patient would need a liver transplant. This is more common in LAL-D than in NAFLD. If you look at the right hand of the slide, you'll see that in various studies of NAFLD, we see that somewhere between 0 and 7% of patients have cirrhosis of the liver, 3% need liver transplantation. And the amount of time to develop liver damage from the diagnosis of NAFLD to evidence of liver damage in the form of fibrosis or cirrhosis was about 7 years. On the left-hand side of the slide, you'll see that in studies of LAL-D, between 16 and 29% of patients had cirrhosis, 9 to 13% needed liver transplantation. And of course, remember, this is just at one point in time. Over time, this can be higher. And nearly 50% of patients who had liver biopsies on several occasions progressed to serious liver damage, fibrosis, cirrhosis, or the need for transplant within 3 years of their first symptoms. So this is a progressive disorder that, if unchecked in many patients, will lead to serious liver damage and possibly to the need for liver transplantation. Now, LAL-D can be diagnosed by a simple blood test. So just as your doctor does a blood test to check your liver enzymes or to check your blood count, they can draw another tube of blood and it can be sent to measure the LAL enzyme activity. So we said that's low or absent, very deficient in patients with LAL-D. And this can be done either on a blood sample drawn from an arm vein into a tube of blood, or really just with a finger stick, a dried blood spot test can also be sent. Now, once you do that test and you see that you have low enzyme activity, your lysosomal acid lipase, your LAL, is deficient, oftentimes we'll also go ahead and look at that LIPA gene to try to identify the specific changes or mutations in the gene that cause the disease. You may want to have a liver biopsy, or your physician may recommend it because that can tell us how far the disease has progressed in the liver. But liver biopsy cannot definitively diagnose LAL-D. You really have to have the appropriate blood test because the liver can look similar in other disorders. There may be some things that cause you to think about it on liver biopsy, but you cannot make a definitive diagnosis solely on liver biopsy. Now, the good news about LAL-D is that the FDA recently approved a medication for the treatment of LAL-D, which really represents enzyme replacement therapy. It's called Kanuma, or Lipase alpha, and it is a form of the enzyme that the patient is missing. So it's enzyme replacement therapy. It's giving back that LAL enzyme that the patient's missing. And this new therapy really has the potential to change the history for patients with LAL-D to prevent these very serious complications that we've been talking about earlier. There are some other supportive management options that we often use, and those may include a low-fat diet, statins, or other lipid-lowering medications to treat the high blood cholesterol. Liver transplant has been done on some LAL-D patients in the past whose liver disease had progressed to the point that they needed that. And something called hematopoietic stem cell transplantation has also been done. Now, there are limitations to the supportive therapies. A low-fat diet often is not adequate to control the high blood cholesterol, and the same is usually true for statins. They may help, but we don't usually get the same beneficial effect we get in patients who don't have LAL-D. Stem cell transplant has been done on some of the very severely affected infants, But this is a very serious procedure with high mortality and is associated with very serious complications. Liver transplant, we mentioned, has been done. It does not cure LAL-D, although it gives you a normal functioning liver. But as we discussed, there are findings of LAL-D that can affect other organs in the body. And of course, liver transplantation is associated with risk as well. Now, our new medication, Kanuma, we mentioned enzyme replacement therapy. It has been shown to reduce or normalize the elevated liver enzymes in the blood, reduce the fat content of the liver, reduce the size of the spleen, and improve the lipids or the fats in the blood by lowering that bad cholesterol, raising the HDL level. It's given intravenously through an IV every other week, for every week for infants, and every other week, every 2 weeks for children and adults. And it needs to be given indefinitely. There are possible side effects of Kanuma, and the main ones are allergic type reactions, which can occur during or after the infusion, that we usually can manage successfully, but they do have the potential to be severe, so the drug has to be administered in the right setting with healthcare professionals who are familiar with how to treat these types of allergic reactions. There are occasional mild side effects like headache or GI upset that also can be observed. So just to summarize what we've talked about, LAL-D is a genetic disorder that results in progressive fat accumulation in multiple organs. It leads to liver damage and an increased risk of heart attack and stroke and other symptoms in many individuals. There's considerable overlap between the clinical and laboratory findings in LAL-D and fatty liver disease, NAFLD or NASH. LAL-D affected individuals may be pretty commonly misdiagnosed with this more common disorder. Increased awareness of LAL-D and more frequent testing is really essential, since this is a disorder that now can be successfully treated. So we want to identify the patients as early as possible in their clinical course so we can prevent those serious complications that I've talked about. I appreciate your attention today and having the opportunity to talk with you, and I think we'll move now to the moderator with the question and answer period.
Okay, thank you, Dr. Burton. We certainly appreciate you shedding light on this rare disorder and explaining some of the features it has in common with fatty liver disease, and telling us about the new treatment option of enzyme replacement therapy in addition to standard supportive measures. We have some questions coming in from the audience, so I'd like to get started with our Q&A session. So one of the questions is that someone is saying that they have been told that they have an enlarged spleen. So if their spleen is enlarged as well as their liver, they'd like to know if it makes it more likely that in fact they have LALD instead of NAFLD.
Hearing you. I hear you a bit, but I'm not understanding the question.
Okay. The person has both an enlarged spleen and an enlarged liver, and they're wondering, with those two symptoms, does that make it more likely that their diagnosis could be LALD over having a diagnosis of fatty liver disease?
Well, both of those things can be seen in both conditions. So we certainly do see an enlarged liver and spleen in some people with LAL-D, but you can see an enlarged spleen with fatty liver disease if your liver disease has progressed to a severe form. So you have something called portal hypertension. So there's overlap between the two, but certainly I think if you have those findings and you don't have a definitive diagnosis, you should talk with your physician about the possibility that this could be LAL-D and have the blood test. It's easy to do.
Okay, thank you. There's another question coming in. I imagine this might be from one of our healthcare professionals, asking if there are histological criteria that clearly distinguish NAFLD and NASH from LALD. And when you answer that, maybe you can explain what that means, the histological criteria.
Sure. The term histological criteria means what you see under the microscope on a liver biopsy. And there are some differences in NAFLD and NASH. The fat that's in the cells is typically what's referred to as macrovesicular, meaning big particles, big blobs of fat, whereas in LAL-D, it is microvesicular, small particles. These are within the lysosome. So that's one difference. And also, if you have a pathologist who is tuned into this, you often see fat accumulation in the Kupffer cells of the liver in addition to the hepatocytes. And for the non-healthcare professionals on the call, hepatocytes are your main liver cells that do all the function of the liver. But these Kupffer cells are, derived from a different source. They're a minority of the cells in the liver, and they have different functions. And we also see lipid accumulation in the Kupffer cells. So that might tip off a pathologist.
Okay, we've got a simple question here from Gayla, and that is, what's the incidence in the population of LALD?
That's a great question, and we don't know precisely, but it's estimated to be somewhere between 1 in 40,000 and 1 in about 150,000. Because we feel that there's been a significant amount of underdiagnosis in the past, it's a little bit difficult to make those estimates, but there have been some screening studies looking for mutations in the gene in various populations that lead us to believe that the incidence is somewhere in that range. So not unlike things like Wilson's disease that we think about commonly in patients with liver disease, we're right in the same category or right in the same frequency as conditions like that. So rare as compared to, let's say, hepatitis C or fatty liver disease, but really there are a significant number of patients out there who have the disorder.
Okay, thank you. We've got Kim asking if this disease co-occurs with any other autosomal recessive disorders or traits.
No, this is independent, so it's not linked to any other autosomal recessive disorders or traits. There are lots and lots of other conditions inherited in the same way, but it's not linked to any of those.
Okay, now we've got Esteban asking, he's saying that he has fatty liver, but his cholesterol levels are fine. So is it possible to have LALD even when someone has good cholesterol levels?
That is possible. So it's possible to have the liver disease without having a very high cholesterol level. It's also, the reverse is possible also. You can have the high cholesterol and not have obvious evidence of liver disease, but both are relatively uncommon. Most patients with LAL-D have both, but it can occur. So I wouldn't want to rule it out without knowing more about his situation.
Okay. There's a couple of questions coming in about Kanuma. One of them being, can it be used to treat other organs that are affected by LALD? So maybe really the question is just what are the effects of Kanuma?
Yeah, that's a great question. Absolutely. Kanuma treats the entire body, not just the liver. So it does have major effects on the liver, but it also causes a reduction in spleen size in patients with enlarged spleen. It treats the GI tract. So if a patient has problems with their GI tract, with pain, with absorbing nutrients, it treats that. So it treats the entire body. We didn't have a lot of time to go into the effects on these very young infants who typically die of their disorder, but there have been dramatic effects of Kanuma in these babies. If they can be diagnosed in time, then we have children now surviving as long as 4 years on treatment who otherwise would have succumbed to their disorder in the first year of life. So it's very effective for them, reducing the size of the big liver and spleen, helping with the GI tract. So it treats all the organs of the body, except the brain, but we don't have problems with the brain in this disease. Any of these enzymes that we give in the blood, they don't go into the brain, but fortunately the brain is not involved here.
Okay, we've got a question from Martina, and she's asking if you think Kanuma might be used in the future for treatment of NAFLD or NASH.
I don't think so. I mean, it's always difficult to say what might happen. We could learn things that we don't know now and so forth. But I think that this is really specifically treatment for LALD.
Okay, we've got Judy asking if Kanuma can be used to treat your average high cholesterol patient without liver disease.
Well, only if the patient has LALD. So if this is just the average patient with high cholesterol, because of obesity, diet, diabetes, or because they have an inherited form of high cholesterol, then Kanuma would not be the appropriate treatment for that patient. That patient is typically going to be treated with other oral medications and diet, but that patient could have LALD. So if you have a patient with high cholesterol, it's something to think about, but only if you confirm the diagnosis of LALD would Kanuma be appropriate treatment.
Okay, we've got a question from Bruce, and he's asking if the effects can be ameliorated if one already is at the stage of cirrhosis of the liver, if you get treated.
That's a great question also, because of course some patients aren't diagnosed until that stage, or they're there now and the drug just now became available, and we don't have the long-term data that we need to really answer that question, but I think there's a very good chance that you could arrest the progression of the cirrhosis and prevent the patient from moving forward such that they go to liver failure and the need for transplantation. So could you reverse the cirrhosis? Well, maybe not. We don't know. It's possible that you could see some improvement, but I think arresting the progression is a very realistic possibility. So definitely I encourage my patients. I have some patients who are already at that stage, and definitely I've prescribed treatment for them and encourage it, because I think there's a very good possibility that that will happen, and also we'll treat the other aspects of the disorder, the cholesterol problems, the other issues that can be associated with the condition.
We have a question from Sherry, and I think this goes back to the genetics of the disease. And she's asking, are there usual multiple people in a family with this disease?
And that's a good question too. And the answer is no, usually there are not, because this is a rare gene. And typically what happens is that there are a lot of carriers in a family, and one of them happens to meet another carrier in the general population, and they have children together and they find out they're carriers, but all the other people in the family who are carriers, they have children with people who aren't carriers of this gene. You know, it's unlikely that two carriers in the family would find another carrier. You know, it's just kind of a coincidental finding one another. There are hundreds of different rare genes, and we all carry a few of them, and usually we have children with somebody who has different ones than we do. So it's just a coincidence when these two carriers come together, and usually it doesn't happen twice in a family. So usually if you look back in your family history, there is no one on either side who has it. Now you might have a sibling who's affected, because the parents have a risk of 1 in 4 in every pregnancy. That doesn't mean if they have exactly 4 kids, one will have it and 3 not. Every pregnancy is a new event. It's like flipping a coin. So if you have a family of 2 or 3 or 4 kids, you may have 2 kids in there who have the disease. So it's not uncommon to find an affected sibling, but it's also very common that there's just one person in a family, because a lot of families just have 2 or 3 kids, and with a risk of 1 in 4 with each pregnancy, you know, oftentimes you only get one who's affected. So there can be siblings, but otherwise we wouldn't expect other affected family members.
Okay. There's a question from George, and he's asking if there are any ethnicities that are more prone to carrying this genetic defect.
Also a good question, and the answer to that is no. In general, we're not aware of any, except for the severe infantile form. We know that it is more common in individuals who are Iranian Persian Jews. They have a higher incidence of the gene, and it may be that as we identify more and more cases around the world, we'll see something else, but right now, no, we see it in all ethnicities.
Okay, we've got a question from Bruce, and he's saying that I'm not sure what site he's looking on, but there are 3 labs listed on an LALD site, and he's wondering if those are the only labs that do testing. So I guess, you know, more broadly, the question is, are there just a few specialty labs that do this test across the country, and is it difficult to get your blood to those labs? Or yeah.
Okay, that the answer to that is there are relatively few labs, but there are ones that are very easy to get your blood to. So in other words, several of the large national reference labs that all hospitals know how to send samples to do the testing. For example, Mayo Clinic, their reference lab, or a big commercial lab called LabCorp. They do the testing, and then there are a number of university labs that also do it. So if you're searching, definitely these big commercial labs are easy to get samples to. It may be that, you know, your physician, if you're at a university center, you know, would find a university lab. So there are a number of different laboratories, but it is not the kind of test that's done in every hospital. I mean, absolutely not. It has to be sent to a special reference lab, but the blood sample could really be drawn anywhere and sent to one of these labs. So I wonder if we might put the American Liver Foundation resources slide up. Those are places where you can get some good information, and also, you know, there are some sites specifically on LALD that you can find if you, you know, Google it. There are some that can give you more information.
Okay, on that note, we're coming up to the 1 hour mark, and so it's nearly time to close the program. So, at your suggestion, we are in fact going to go to our next slide, which is a slide of resources at the American Liver Foundation. And here we've listed some ways you can tap into ALF resources, including visiting our website and calling or emailing our national helpline, which is open Monday through Friday, 9 a.m. to 7 p.m. Eastern Time. You can also download education materials, get access to a drug discount card, and join the American Liver Foundation online support community on Inspire and connect with other patients and their families to share experiences, information, and support. On the next slide, we have a number of different organizations that deal with financial support for prescription drugs. The webinar will be posted on our website following this live event, so don't worry about jotting down all this information. You can access it later. I have some additional resources listed that are specific to LALD, including an LALD online support community, contact information for NORD, which is the National Organization for Rare Disorders, and one source. That's a resource for those people who have been prescribed Kanuma. So in conclusion, we encourage you to stay active with the American Liver Foundation. You can do that in many ways and help the organization at the same time. Think about joining one of the many fun fundraising activities we have across the country by joining a walk, a run, or dining at a flavors event, making a small donation. Any of these things help us with our mission to serve you and be the national voice of all patients with liver disease. Again, thank you to our guest speaker, Dr. Burton, and to our funder, Alexion Pharmaceuticals, for making this program possible. For those of you interested in taking a closer look at the program slides or revisiting the Q&A discussion, a recording of today's program will be posted on our website within the next day or two. We ask that you please complete the evaluation survey that pops up when the program ends. We appreciate and do pay attention to your feedback. This concludes our program for today. Thank you for joining us.